Hello everyone, today we will talk about acute bronchitis in children. So let's begin. In today's lecture, we will cover the causes of acute bronchitis, the pathogenesis, the symptoms, and the examination plan, including the interpretation of labs and the instrumental studies, and the best treatment approach, and finally we'll talk about the prognosis. And after that, we will also speak about the obstructive bronchitis. So, acute bronchitis is one of the most common respiratory illnesses in children. We will see inflammation of the bronchiolite that will lead to a cough and mucus production. So this is a quick revision. We will have the trachea, then this will give us the primary bronchus, then the primary will give us the secondary bronchus, and we will keep going until we reach the alveolar sac. So we will have the inflammation in the bronchus, not the bronchioles. This will give us another disease, which is bronchiolitis. Now we will speak about bronchitis. So the etiology of it, like the cause of the disease, could be viral, could be bacterial, or could be non-infectious. So the viral causes are the most common, about 90% of the cases. It can get caused because of these viruses: respiratory syncytial virus, influenza A and B, parainfluenza virus types 1 to 3, adenovirus, rhinovirus, coronavirus, and human metapneumovirus. The bacterial causes are less than 10% of the cases. For example, we have Bordetella pertussis, which will give us the whooping cough, Mycoplasma pneumoniae, Chlamydia pneumoniae, Streptococcus pneumoniae, Haemophilus influenza as well. These are the bacteria that could cause bronchitis. And the non-infectious causes are exposure to smoke, dust, pollution, chemicals, allergic reactions, asthma-like bronchitis, or the gastroesophageal reflux disease. That's why it's important to ask the patient about we will have a children, so we'll ask about the living condition. Maybe they are in an area with what do you call it, factories or something, so they are exposed to dust or pollution things. Now we will speak about the pathogenesis. So first of all, the virus will enter and infect the epithelial cells of the bronchus. This will initiate an inflammation. The inflammation will, when we have an inflammation, cytokines will get released, like interleukin 6, 8, and tumor necrotizing factor. This will increase the permeability of the mucus layer, and we will have an edema. The edema will cause a narrowing in the airway passage. Then, goblet cells will start an increase in the production of the mucus, will furthermore do an obstruction in the airways. We will have a ciliary dysfunction, so the mucus clearance function will get impaired. That's why we will have a productive cough, and eventually in the severe cases we will have a bronchospasm and hypoxia. So let's speak about the clinical symptoms. The early symptoms are similar to a common cold, so we will have a rhinorrhea, runny nose, we will have a nasal congestion, we will have a low-grade fever, sore throat, and a mild cough. In the beginning, it's dry. Then we will have the main symptoms. We will have a cough. First of all, it's dry, then it will become productive with mucus. We will have wheezing due to the airway narrowing and the bronchospasm, chest discomfort and pain worsening when coughing. We will have a shortness of breath, more common in younger children. We will have fatigue and malaise as well. So for the examination plan, first of all, we'll do a physical examination. We will find out that our patient have a mild fever and mild respiratory distress. We will perform an auscultation. In the early stages, we will have wheezing and prolonged expiration. Then we will have crackles due to the mucus accumulation. If there is only normal sound, so it's just a mild bronchitis. So first of all, let's listen to the wheezing sound. So I think now we are familiar with the wheezing sound. Sometimes the wheezing could be audible by ear. Not in the bronchitis case. Bronchitis is not a severe disease, but sometimes wheezing can be heard by ear. So we have a video here.
Candle on.
So this was an audible respiratory wheezing, and the first video was an auscultation of wheezing. Now let's hear the crackles. To be honest, in real life it will be a little bit different, but this is a good example for it. I hope it's clear in the video. This is the first time I do something like this, and I'm not that experienced with YouTube. So, this is a beautiful thing I created. So, we'll have an expiratory wheeze and bronchitis, bronchiolitis, asthma, COPD, foreign body aspiration, expiratory wheeze. Inspiratory wheeze, stridor-like sound, we will have it in crop. This will have it in laryngitis, the next lecture. Upper airway obstruction, and both biphasic wheeze, we will have it in severe airway obstruction or severe crop anaphylaxis. Just to keep you aware that the wheeze is not just every time we will hear a wheeze, we'll say, oh, we have a patient with bronchitis. It could be COPD, it could be asthma, it could be just foreign body aspiration. So then we will move to the lab test. Just let me check if the mic is working. The mic is working. So we will move down to the lab test. First of all, we have CBC, complete blood count. If it is a viral case, we will have normal or mild leukocytosis, lymphocytosis. If it is a bacterial, we will have leukocytosis with neutrophilia. CRP and ESR, we have them normal in viral cases, but elevated in bacterial cases. We have procalcitonin, and if it was less than 0.5 nanogram per milliliter, it's likely viral. If it's more than 0.5, it's a bacterial. By the way, the normal value is less than 0.1, and this one, like, it's 0.5 to 2, it could be just nothing. So more than 2 is most likely a bacterial infection. We can do a PCR if we are suspecting any viral infection, and yes, or serology for any viral infection if we have the symptoms of them. For the instrumental studies, chest X-ray is not a routine examination, only if we suspect a pneumonia for the patient. In our case, it could be just normal and uncomplicated acute bronchitis, or we will have a hyperinflation in viral infection or pre-bronchial thickening. Pulmonary function test, the PEF, it will get reduced, and if we perform the bronchodilator response, this is a test, we will give the patient we will take the reading of the PEF, then we will give him a bronchodilator drug, and we will take the reading of the pulmonary function test again. If it's improved, that will suggest an asthma, so we won't get a response here because it's bronchitis. If it gets improved, that means it's asthma. So this is how to assess hyperinflation in the chest X-ray. To be honest, it's not really clear in a picture this small, but just know the signs. If you will hold the real X-ray, it will be really easy to detect it. So first of all, you will see more than 6 anterior and 10 posterior ribs. We will have flattening of the diaphragm and the increased lucidity of the lungs field. So these are the signs. Maybe if you just zoom in now from YouTube, you could really see those signs. So for the treatment plan, first of all, we will have a supportive therapy. We'll keep the patient hydrated. We will give him, we will make him like maybe take a shower and have some steam inhalation, or we put a pot of water above some heat or something and let him breathe this steam, because it will help relieve the cough. And he could rest and get proper nutrition. Honey, so for example, honey is a natural cough suppressant, so we give it for children more than 1 year, because the cough suppressant drugs are not that much safe for children, so just give them honey, not drugs. So then we'll have a symptomatic treatment. We'll give antibiotic drugs for if they have fever more than 38.5 Celsius, paracetamol. We avoid giving ibuprofen to patients with asthma. This is because ibuprofen is NSAIDs and it have some bronchospasm effects, so it will just worsen their asthma. For the cough management, if the child had a dry cough, we can give him dextromethorphan, but this is in older children. This drug is not safe for the children under the age of 12. If you have a wet productive cough, we can give him mucolytics to help with the mucus discharge, but this drug is not safe. Any drug of mucolytics is not safe under the age of 6. We can give a bronchodilator if the wheezing is present. Bronchodilators are safe for children. We can use antiviral therapy as well, acyltamivir for example, and it's actually safe for children above the age of 14 days. But this drug should be used within 48 hours of the first beginning of the symptoms, after maybe the child was exposed to a person who have viral infection or something. Contraindications, so don't give children antibiotics if it's not confirmed that they have a bacterial infection. Avoid antihistamines. Avoid codeine-based cough syrups, because it creates the risk of respiratory depression. And corticosteroids only if they had bronchospasm, severe bronchospasm or asthma. Corticosteroids are actually safe for children. A prognosis. So in the mild cases, it will get resolved from 7 to 14 days without complications. In severe cases, especially in infants less than 6 months or immunocompromised children, they will have a higher risk of progression to pneumonia or respiratory failure. If the patient had recurrent episodes of bronchitis, consider asthma, gastroesophageal reflux disease, or immune deficiency. Now we'll speak about the obstructive bronchitis in children. It's not a completely separate disease, it's just a, let's say, more severe bronchitis. Here we will have a greater degree of obstruction in the airways and more wheezing and prolonged expiratory phase. So, the early symptoms, it will start like acute bronchitis, cough, runny nose, fever. We'll have a dry productive cough. We'll have a low-grade fever. Then it will get progressed to obstructive symptoms. We'll have expiratory wheezing. We already heard it there. We'll have a prolonged expiration, so the child will have hard time breathing the air out. And you'll have chest tightening, increased respiratory effort, tachypnea, fast breathing, retractions, nasal flaring. Episodes may be recurrent, especially in children prone to asthma. In the severe cases, we'll have cyanosis, respiratory failure signs, apnea, for example, and severe air trapping. We can see the barrel chest appearance in some cases. For the treatment plan, we start with supportive care, hydration, nasal suction for infants, and oxygen therapy if the oxygen saturation was less than 92%. We can give bronchodilators, and here it will work. It will work not like in the bronchitis. Albuterol are actually safe to give for children. We can give corticosteroids for severe cases or recurrent cases, and corticosteroids are safe for children. And as well, we don't give the children antibiotics, antihistamine, cough suppressants for the same reasons. And we should admit the children to the hospital if we have cyanosis, apnea, saturation of oxygen less than 90, dehydration, unable to feed them because of tachypnea, and recurring severe episodes. So this is just a comparison between acute bronchitis and obstructive bronchitis. The cause in acute bronchitis are mostly viral. Here, viral and airway hyperreactivity. It will happen in the larger bronchi. Here, we'll have more obstruction on the small airways. The wheezing, it could be mild or absent. Here, it's more prominent and prolonged expiration. We will have a minimal response to bronchodilators. Here, they will get improved. And that's actually everything about bronchitis and obstructive bronchitis. I think some of the parts here maybe the lesson got boring because I'm just reading, but I didn't know what to add, so please forgive me for that. I hope you found this useful. Thank you so much for watching and have a great day. Goodbye.